Hi guys, welcome to Easy Medicine. The topic for discussion today is Phaeochromocytoma. It is also called as the Great Masquerader because of its numerous clinical manifestations and varied presentations. Phaeochromocytoma is a tumor that produces catecholamines and is derived from the sympathetic and the parasympathetic nervous system. Before we go into the topic proper, let's look at the brief anatomy. The innermost part of the adrenal gland is called as the adrenal medulla, and it is also derived from the neuroectoderm along with the sympathetic and the parasympathetic nervous system. In the medulla, the cells are the modified neuronal cells and they produce catecholamines. In the order of the amount, adrenaline is produced in the highest amount, then comes the norad, then comes the dopamine. The property of the catecholamines is to stain dark on oxidation. This is called as the chromaffin reaction. And because of this reaction, the cells which are located in the in the adrenal medulla are called as the phaeochromocytes. Pheo means dark, chrom means color, cytes are the cells. When a tumor arises from the sympathetic ganglion, we call it the paraganglioma or the extraadrenal phaeochromocytoma. And the most common site is the organ of Zucker candle. This is an area where the aorta is bifurcating in the abdomen, and that is the area of high concentration of sympathetic ganglion. When this tumor arises from the parasympathetic ganglia, again it is called as the paraganglioma or the extraadrenal phaeochromocytoma. And the most common site is the carotid bulb and can also be present in the glomus jugular. The tumors arising from the parasympathetic ganglia are usually present at the base of the skull. A tumor arises from the adrenal medulla, we call it the phaeochromocytoma. So the phaeochromocytomas are sporadic of up to 60 to 70% of cases, and 25 to 30% are hereditary or familial. The genes that are responsible for the familial phaeochromocytoma are VHL gene responsible for the von Hippel-Lindau disease, NF1 whose mutations will lead to neurofibromatosis 1, red proto-oncogene responsible for multiple endocrine neoplasias, and SDH gene is responsible for the succinate dehydrogenase enzyme in the Krebs cycle. There has been something called as rule of tens in phaeochromocytoma, and the recent data has some little changes to it. So what are the rule of tens? 10% are bilateral, 10% are extraadrenal, 10% are malignant, 10% in children, and 10% are familial. The new data says 10% are bilateral only when the phaeochromocytoma is sporadic. When it is familial, it increases up to 30%. 30% are extraadrenal. 10% are metastatic. The word metastasis is important here rather than malignant. So much so that WHO has entirely replaced the term malignant phaeochromocytoma to metastatic phaeochromocytoma. We'll learn at the end why. 10% are seen in children and 30% are familial, or 30 to 40% are familial. Let's look at the clinical features. Most of the clinical features are because of increased levels of catecholamines, and you can see a lot of P's here, P for pen. Paroxysmal or the persistent hypertension, postural hypotension as well. Paroxysmal hypertension is because of sudden increase in catecholamines, and persistent hypertension can be there when there is persistent high levels of catecholamines. Why is there postural hypotension? Because of this catecholamines, there is significant elevation in vasoconstriction, and this vasoconstriction will lead to hypertension. And this vasoconstriction will also result in volume contraction. This volume contraction will lead to postural hypotension as well. And the patient can also have palpitations, tachycardia, panic attacks, anxiety, perspiration, or the profuse sweating. All these features are because of the increased levels of catecholamines. The patient can also have polyuria, polydipsia. This is because the catecholamines have the inhibitory action on the ADH. When the ADH is inhibited, the patient will have diuresis, and again that results in polydipsia. The patient can also have pallor. This pallor is because of peripheral vasoconstriction, and because on appearance, the patient will appear pale. Then comes polycythemia. Why is there polycythemia? This phaeochromocytoma can also produce erythropoietin. That is the reason. And the patient can also have pain abdomen. This pain abdomen is uh, supposed to be because of hemorrhagic necrosis inside the tumor. And sometimes because of intense vasoconstriction, there could be ischemic bowel as well. Because of that also the patient can present with acute abdomen or pain abdomen. The patient can also have headache because of paroxysmal increase in hypertension. On the heart, this catecholamine will have cardiomyopathy. It is the dilated cardiomyopathy, or you can also call it as the Takotsubo cardiomyopathy. It is again because of increased levels of catecholamines. The patient can develop hypercalcemia. This is because of the production of calcitonin from the phaeochromocytoma. And hyperglycemia is because of the sympathetic overdrive. The patient can also have constipation because of the dilatation of the smooth muscle. And the patient can have weakness and weight loss. Now that you've seen the clinical features of the phaeochromocytoma, let's move ahead with the evaluation. When you clinically suspect that the patient is having a phaeochromocytoma, you'll have to screen the patient using the urine test or a plasma test. For that, you will do 24-hour urine catecholamines or the fractionated metanephrines. Metanephrines are nothing but the products that are derived from the metabolization of the catecholamines. Or else you can also do the plasma catecholamines or the metanephrines. If any of these levels are elevated, it means that there is some tumor that is producing these catecholamines. In order to localize them, you have to do the radiological investigations, that is contrast CT or MRI abdomen. After you localize the tumor, you also have to look at the chance for the metastasis. So for that, you will do the scintigraphy or the radiotracer uptake scans. There are multiple scans. They are MIBG, FDG PET, gallium dotatate PET, and the DOPA scans. MIBG stands for meta-iodobenzyl guanidine, FDG for fluorodeoxyglucose, and GA is gallium. These scans depend on the radiotracer uptake by the tumor, and when you scan them, they will be enhanced. So when you look at the first image, the radiotracer uptake is predominantly high at the bilateral suprarenal gland. This indicates bilateral phaeochromocytoma. In the second image, you can see that the radiotracer uptake is increased at multiple focal points along the spine. These indicate multiple paragangliomas. And in the third image, you can see along with the radiotracer uptake at the suprarenal gland as well as along the spine, you can also see multiple focal uptakes dispersed throughout the body. These are the metastasis. So among all the investigations, which is the highest and highest sensitivity and specific? That is the dotatate or the DOPA scan. When you look at the biopsy, the pathology pattern that you see here is called as a Zellballen pattern, and the sure sign of malignancy is metastasis. Why is this term metastasis important here? Is because of the reason that the general cytological features of malignancy like increased cellular atypia, increased number of mitotic spindles, and increased nuclear cytoplasmic ratio can be seen in a phaeochromocytoma even if it has not metastasized. And also the prognosis and the treatment of the patient significantly changes when there is metastasis of phaeochromocytoma. Let's look at the treatment part. Since the phaeochromocytoma is a tumor, if it is located focally, removing the tumor is the obvious treatment of choice. So the treatment of choice is total or the partial adrenalectomy. And before you go ahead for the surgery, you have to control the blood pressure to a level of less than 160 by 90 millimeters of mercury. So as soon as you diagnose the patient of phaeochromocytoma, firstly admit the patient. Then start alpha blockade. For that, you will use an orally given long-acting alpha blocker, that is phenoxybenzamine. While this takes some time for the alpha blockade to set in, the patient can also have paroxysmal hypertension meanwhile. For that, you can add short-acting alpha blockers, that is oral prazosin or the intravenous phentolamine. After the alpha blockade has set in, then you can start blocking the beta receptors as well. So for that, you will use beta blockers like propranolol. Can be started at a dose of 10 milligrams TID or QID. And after the blood pressure is entirely under control, you can take the patient for surgery. In the surgery as well, upon little manipulation of the adrenal gland, there can be release of catecholamines from the tumor into the circulation, which can further lead to paroxysmal hypertension. Okay, in those situations, you can use the drug intravenous nitroprusside. Because of volume contraction prior to the surgery, the patient may also have hypotension. For that, what will you do? You will give some IV fluids or the volume correction. Okay, and after all these, you can go ahead with the laparoscopic adrenalectomy. A drug called as metarepone will also inhibit the catecholamine synthesis. It can be used in the medical management of phaeochromocytoma. So now that you've seen, first you will block the alpha blockers, then you will block the beta blockers. There has been multiple questions on this topic. The base question is, why not beta blockade first? For that, you have to understand the receptor action first. The alpha 1 receptors will mediate the vasoconstriction, and this vasoconstriction will lead to increase in blood pressure. While the beta 2 receptors mediate the vasodilation, and that will decrease the blood pressure. So when you block the beta receptors first, what will happen? This unopposed action of alpha receptors will lead to severe hypertension or the hypertensive crisis and can lead to pulmonary edema as well. That is why we have to first block the alpha receptors. So when you block the alpha receptors, this vasoconstriction is relieved and the patient will have vasodilation. Then you can also block the beta receptors. Let's look at the management of the metastatic phaeochromocytoma. Here you are using the radio tracers which can emit the radiation and can damage the tumor. The first line is iodine 131 labeled MIBG at a dose of 100 to 300 millicurie over 3 to 6 cycles. You can also use yttrium 90 labeled Dotatoc or lutetium 177 labeled Dotatoc. There is a protocol specific to metastatic phaeochromocytoma, which is Averbukes chemotherapy protocol, which includes the usage of 3 drugs. They are dacarbazine, cyclophosphamide, and vincristine. These are to be used for 3 to 6 cycles. That completes the management of phaeochromocytoma. Thank you. Please do like, share, and subscribe to Easy Medicine.